they are doing some presentations and we're going on a field trip to see some bathrooms. So welcome back, and we've had a great start to the day so far, and we'll continue with Dr. Ravi. So Dr. Ravi is someone who's worked in the field of surveillance and neurological infectious diseases for over 40 years, as he said. He was based at NIMHANS, and NIMHANS is really an amazing place where there's excellent science embedded in practice. It's a practicing hospital with a lot of science, very rare in the Indian scenario. So we're really lucky to have him. He's come from a long distance. And I got to know Dr. Ravi through my interest in infectious disease and also through our interactions during the COVID time. So he's going to talk to us about how he really spearheaded this whole thing in Karnataka. Dr. Ravi, thank you.
Good morning. Thank you, Dr. Uma, for inviting me back to the academic world. I've been off for some time. So what I will do in the next hour or so is to have a discussion. It's always difficult to come after somebody like Tenzin, whom I've known for more than a decade now. She's a wonderful teacher and has very rich experience. I've been very fortunate in my career, spanning over 45 years, to have worked with surveillance of almost every infectious disease. Some of it starting from scratch. And the ones that I can tell you we started from scratch was HIV surveillance in 1989, even before NACO was constituted. And of course, my passion has been arboviruses and then respiratory viruses. So every surveillance system that has been set up and is working in India, I happen to be associated with it. I won't claim that I contributed to it, but certainly that has broadened my horizons. I'm a clinical virologist by training, but more than 80% of what I did was public health. So that's the way it is in India, right? You're trained in something, but you're thrown into something else. But I enjoyed every bit of it. Uma requested me to make it more interactive, so feel free to interrupt me. How many of you here use mind maps? Do you know what a mind map is? That's homework number one. I'm very notorious to give homeworks. I will not check on them. So relax, right? I think you should start your career or your work with a mind map. I never knew what a mind map was till I was 45 years old. 2000, I went to a parent-teacher meeting of my two sons, who are now grown up and well established. So the headmistress of the school taught me what a mind map is. I was asking them, do they use mind maps? A mind map is a whatever you want to do, put it down there. And today our topic is setting up surveillance, right? So how do you use a mind map? Basically ask the 6 common questions that you do in life or anything, right? What is it? Why do we do it? How do you do it? When do you do it? Where do you do it? Start answering these questions. It goes down into a dendrogram. Do this. 50% of whatever you do, you devote to planning. Thrash out everything by discussing, putting it on a piece of paper. then your execution becomes meaningful and easy. I remember the slide that Tenzin put up saying that we ended up having more controls than cases, right? It's not a criticism, but this is what happens. Once you go into a field, so even before you go into a field, now today with technology, all this is possible. By the way, there are more than a dozen mind mapping tools available for you. If you're a technology fad, you can create mind maps. So this is what I will be doing in the next 1 hour. What is surveillance? I don't want to insult you, but this is for my own delivery purpose that I start from basics. I'm sure all of you know what surveillance is, right? Why do we need surveillance? Already, Dr. Tenzin has made a very beautiful case of why we need surveillance. Surveillance is the background on which you detect outbreaks. Very simple. If you don't have surveillance, you will be caught off guard for investigating an epidemic. What are the basic ingredients of an effective surveillance? By the way, these slides are about 20 years old. That's why you can see the blue background and white. And we used to teach in WHO course. You can see WHO Quality Management, March 2002. I've not changed anything there, okay? And this was Tenzin with Rajesh Bhatia. We ran this course all over Southeast Asia. I worked a lot for WHO. So. What do we do in surveillance? What are the activities we do in surveillance? What are the various types of surveillance? You would have heard all this, but nice to crystallize it so that we have clarity on what we are discussing. Laboratory plays a very crucial role in surveillance, and I can vouch for it from my 4 decades of experience, and so will Uma. Both of us battled COVID together. She was my partner in crime here in Karnataka. How does one set up surveillance? Let's take the steps that are required because we are talking about emerging infectious diseases, known and unknown, right? Examples of surveillance in India, outputs and outcomes. From my experience, what I have learned, what my team has done, for which I take credit. I'm a very, very simple person. My team does all the work and I do all the talking. That's the way we divide labor in our. What is the future plan for surveillance in India? I told you I would show you a document. If you are interested in this area, I think you should be reading that document. It's available online. So what is surveillance? You can get 1,000 definitions of surveillance, but this is the simplest way I could understand what surveillance is, so I'm sharing this definition. It's a systematic collection, collation or compilation, analysis and interpretation of data. Data is very crucial. How you collect, what is the quality is very, very important. And the dissemination of this information, not to keep it yourself, right? For what? For action. In short, it is information for action. So this is surveillance. This is the simplest way I can describe what is surveillance. What are the basic ingredients of surveillance? Whenever you want to set up surveillance for human diseases or even for that matter animal diseases, I think you should have a definition. Without boundaries, it is like AI. How many of you use AI here? Surprised, not even half. Last 1 year I've been doing only AI. AI is as good as you are. You feed garbage, it will give you garbage. It will give you wonderful garbage. And I don't know how many of you have experienced this. It hallucinates. I'm not joking. Whatever I'm telling is very serious. Maybe it sounds humorous, But actually, I've caught it hallucinating. Right now, I am in a very challenging project where we will probably close it in 2 months, and I'll just describe it for you, and that is completely automating doctor-patient interaction. Doctors will not have to use any gadget other than their smartphone, where there is an app with the consent, whatever you record. There is conversational AI and there is generative AI. I won't talk about it because that's not the scope. At the end of it, it will generate clinical notes, which will populate an electronic medical record, and based on the patient's history and laboratory findings, generate a care plan specific to the patient and give you what are the tools that you have to monitor the patient. It's made me younger. So you'll have to have a case definition. You can put whatever you want in it, 100 elements in it, but stick to that. You have to have a definition. Otherwise, you will go all over the place. Clear case reporting. Who is going to collect the information? Where it is going to be reported? How is the record going to be kept? Effective communication. COVID taught us a lot. We started communicating outside our own comfort zones. Sound epidemiology. Dr. Tenzin gave you already the fundamental principles of epidemiology. Good laboratory support if you want to close the loop. And of course, feedback and quick response to the feedback. These are the basic tenets of a good surveillance system. What do we do in surveillance? Well, like anything else in life, if you ask what do, you first use an algorithm. These are the core things I do. These are also the other things I do. The core functions of surveillance are case detection, case reporting, investigation and confirmation, analysis and interpretation, and then that should result in action. Remember, surveillance is information for action. If it doesn't, then you have not closed the loop. And again, it's a cycle. It keeps going on and on. You have to do the same boring thing for 45 years. When you want to do all this, you also have to have training of the people, supervision, you should have resources, and you should have a set of guidelines for people to follow so that they don't do their own surveillance. There are different types of surveillance. To give you some examples, sentinel surveillance. This is what a lot has been done. I have taken one disease where I have worked through all these surveillances and giving you an example, HIV. Sentinel site. You have to have a sentinel site. What is a sentinel site? In the early 90s, mid 90s, because we knew it was spreading rapidly due to sexual activity, we set up sentinel sites where commercial sex workers were there. We also set up sentinel sites where men were having sex with men because that's a high risk for HIV transmission. And also in the Northeast, in Manipur and other places where IV drug abuse. So covering both the sexual route and the intravenous route. You define a population and say so many will be sampled every year to look at the trend. And also if you get a virus there, to look at if it is changing, to look at behavioral factors. In fact, there's something called behavioral surveillance. Why such behaviors are taking place? What are the drivers for those behaviors? So surveillance is not restricted only to infectious disease. You can have it for environment, for human behavior. Integrated disease surveillance, which is the biggest surveillance platform in this country. In fact, WHO came up with this concept several decades ago, and we have been doing it in India. Laboratory-based surveillance. This is what we did in COVID. A lot of data came from the lab results. and we drove back, and I'll give you an example later. Community-based surveillance. This is what I told you about behavioral surveillance. Event-based surveillance. The most powerful lobby for event-based surveillance is what? Television. Right? They report there's an outbreak of encephalitis in Gorakhpur. There's diarrhea somewhere. There's an event somewhere, right? And then, of course, passive surveillance is just collecting data in a hospital and then trying to make sense out of it. It's not active. You're not doing anything actively. You're just sitting in your lab and collecting reports, or hospital and collecting reports and doing. So you will have to decide what type of surveillance you want to establish. There are a number of surveillance methods available there. Lab, as I said, is very, very crucial in surveillance as much as it is in outbreak investigation in order to find out the etiology, right? The confirmation of a particular infection comes from the laboratory by isolating the pathogen or showing genetic material of the pathogen in an infected individual, but not in controls. Surveillance, the lab also helps in surveillance to know if a population is protected or not protected. Dr. Tenzin was talking about immunization and COVID and how it came down. No, nobody bothers, right? If you have an upper respiratory infection, whether it's COVID or not, nobody bothers because we all are protected against COVID. So that you're protected, the immunological status will come from the lab. It's very important to have the lab in disease elimination phase, and a classic example is polio. Polio is not there in India. It's there in a couple of countries in the whole world, but still polio surveillance will never stop because we have to know if there is a case somewhere of wild polio. And also whether it's wild polio or the virus that you got from the stool is from the vaccine. Okay? So lab has a very critical role, and surveillance for polio will continue. It will never end because we have not eradicated. Detection of new pathogens, we all know. COVID is a standing example for us that we picked it up because of laboratory evidence. Laboratory services are also useful for a number of things, for detecting the pathogen, for treating, food and environmental services. Dr. Tenzin gave you examples of Shigella, foodborne outbreaks, John Snow, cholera, and of course, studying more about the bug, how it causes disease, what are the virulence factors. We all know from COVID how so much of work was done in such a short time. Laboratories are not there everywhere, but they are a tired system, peripheral, intermediate level, state level, and national level. It's a network. Networks support investigations and surveillance. So now we have large number of networks in the country. We have the ICMR network of more than 160 viral diagnostic research laboratories. We have the TB network. We have the NVB-DCP vector-borne disease control network. We have very recently the antimicrobial resistance network of ICMR. So there are a lot of laboratory networks. So these networks are very important, and you should know when you set up surveillance to which of these networks you can plug in, because you can't be doing everything. You should know where to plug in. This is the largest network that is available globally, and this is the polio network. And then, of course, you have also the influenza network, and you have the influenza, and recently, as I said, you have the AMR network. How do you set up surveillance? What do you do when you have to set up a surveillance? I think first is do a mind map, look for data, mine data, and see what is existent available to closest to the disease that you are talking. Is it a respiratory disease? By the way, I forgot to tell you there's something called syndromic surveillance. I'll come back to it. Syndromic surveillance, syndrome in medical language means several different diseases having same symptoms and signs. Okay? Acute encephalitis syndrome. Encephalitis is fever, altered mental status. You can get that in viral infection, in bacterial infection, in parasitic infection. So many. So syndromic surveillance is a strategic way of trying to collect data on diseases with similar manifestations or presentation, right? And remember, the objective of surveillance is to have a fishing net that will capture big fish, small fish, round fish, starfish, every fish. From there, you sieve out and find out your pathogen. So it is like a fishing net. So you will have some background surveillance for the disease that you want to work on. Pick on that, and then improve your and set up whatever you want to set up. Identify and prioritize the emerging disease. What will you prioritize? If I ask you to prioritize today, what will you prioritize among emerging infectious diseases? What will you prioritize?
Dengue, someone says dengue, influenza.
Influenza, very good. Why influenza?
Previously, there are like many pandemics and occurrence is possible again. We have.
Filovirus.
That's the, yeah, please.
Filovirus. Some filovirus.
Yeah. Filovirus. Deadly virus. See, both with influenza and filoviruses, like Ebola. I tell you what the biggest danger is. They spread like wildfire. Very easily it spreads, and you cannot prevent the spread so easily because it involves a lot of human behavioral change. All I have to do is sneeze with a new respiratory virus. Rather than saying influenza, any respiratory infection that is spreading fast, you would want to see is it a new virus? Any deadly hemorrhagic virus. Dengue comes there, Ebola comes there. But dengue gives you so much of time to act. Ebola does not. It starts spreading very fast. Nipah, because it's not in your control. Bat contact with human is inevitable. You cannot stay away from bats. There are areas, right? So you have to prioritize. What is the emerging infectious syndrome that you want to work on? Is it respiratory? Is it brain? Is it hemorrhagic? Is it jaundice? Is it diarrhea? I don't know, but you have to prioritize.
So basically, the idea of prioritizing a syndrome makes it more clinical, isn't it? Like the fact that you're saying it's a hemorrhagic fever.
Correct.
So that allows you to give those instructions to clinicians that,
Just
when you
stepped
see
out, I
hemorrhagic,
was telling them,
Yeah.
the idea of surveillance is to have a net in which you capture everything, right? So syndromic surveillance is the net in which you capture whatever you want, okay? Whenever you set up surveillance, remember two things are very important. What tools are you going to use? What is the quality and completeness of the data that you collect? I will give you an example in a subsequent slide on what we did on COVID, and Uma knows about it. You have to train people who are going to participate. Every surveillance, it requires training so that there is consistency in what we do. Whether it is specimen collection, data collection, reporting, or communicating, there should be consistency. You should have real-time data analysis Boss, you are the luckiest lot, I can tell you. The click of a button, you have analytical tools, right? But you should know how to use them. Don't be a slave of technology, but use it for the right tool for the right purpose. You have to be a mechanic, good mechanic, right? You have to collaborate. COVID taught us that does not matter whether it is NCBS, which is a research institution, or whether it is NIMHANS, a hardcore hospital virology lab. We all learned from each other. Okay? You have to have, and even Dr. Tenzin made this point, ecologists are not involved in surveillance today or in outbreak investigation. It's time we do that, right? Plug into a friendly neighborhood environment. And those are very few. My tribe, no, is a very difficult tribe. I belong to that medical community, right? The very hierarchical, esoteric, look down on others. But there are some people you can definitely find there also. And they are also now open, after COVID, a lot of them are open to finding out answers to questions. There has to be monitoring, continuous monitoring and evaluation, interim results, course correction, like whatever you do in your research project, same things apply in surveillance. Funds, without funds you cannot. But fortunately, this is one area that is well funded in the health sector. Surveillance is something that is well funded. And all this, you should involve the community. Because if there are some simple actions like telling people, don't store water in an open drum for more than 3 days because larva will breed there and it will be a source of dengue for you. Currently what's happening in Bengaluru, right? Now who has to do that? Government cannot go to every house and drain the water and refill it, right? So you'll have to drain come. There used to be a very, very effective Kejriwal. I'm not a fan of Kejriwal. But there's a Kejriwal message that used to come on the television. I don't know how many of you have watched it. You say every Tuesday empty it, then refill it again on Saturday, something like that. Just to, because there were huge outbreaks of dengue in Delhi. And you know why? Because of water coolers. A lot of mosquitoes breed in water coolers. So these are the fundamental steps involved in setting up surveillance. Now I'll go to something that I want to give you a flavor of the type of things we did. Acute encephalitis syndrome, right? It's a very serious brain infection, mostly involving children, and it comes in waves year after year. It's a syndrome where the definition is very broad. It's an umbrella term that has bacterial, viral, parasitic, and non-infectious causes. I had the privilege of investigating 2 non-infectious outbreaks. One was in Saharanpur. Tenzin is not here. Tenzin will know this. And the other was the famous lychee encephalitis in Muzaffarpur, right? Both, first lesson when you go to you have to have your ears, eye. By the way, surveillance, when you want to do surveillance, please wear your shoes and get onto the field and don't come out till there is a hole in the shoe. Any of you have been to Atlanta, CDC? There's a museum. Please go there. And it is the logo of the EAS course in Atlanta, a hole in the shoe. Get out into the field, it's what it says. There's nothing like going into a field. When you walk into a village or an area, you can smell what infection it is. Look around. These were midsummer encephalitis. Midsummer means highly unlikely to be an infectious agent, excepting if it is central India. That outbreak also I was involved in investigation. That is called Chandipura, a viral fatal encephalitis. 50% of the kids die. Very dramatic illness. Child is playing, mild fever, evening goes to bed, dies early morning. You see the side, there will be huge papular rashes because it's peak summer in Telangana and in southern Madhya Pradesh, western Maharashtra, very hot, 45, 50 degrees. That's not an infectious disease that's commonly seen at that time. All encephalitis, by rule, are post-monsoon because they are vector-borne. They are the main causes of vector-borne. So season, the terrain, and there were no paddy fields around. These are dry areas. So it was not Japanese encephalitis. Then we started hunting, and finally, NIV isolated Chandipura virus from the blood of a patient and then caught hold of sandflies. Sandflies are the ones that transmit. Okay. Muzaffarpur, lychee encephalitis. It's the peak of summer, 3rd week of May to 4th week of June, the whole outbreak is over. And these are families of poor laborers who harvest lychees. Their children don't have food whole day. They play in the fields, they consume lychees. And when they come back home, they're so tired they sleep. Middle of the night or early in the morning, they have fits, and by afternoon they're dead. Very, very dramatic illness. Then by systematic investigation, CDC USA, NCDC, NIMHANS, all of us found that there is a toxin in the lychee fruit, ripened fruit, that reduces blood glucose. Compounded with malnutrition, compounded with the fact that the child missed an evening meal, blood glucose level goes critically below 50 milligram per deciliter. The child has seizures and dies. All the intervention that was told to Bihar government was make sure that children get an evening meal. Wake them up and feed them. Very difficult. See, behavioral interventions are very, very difficult. I come from NIMHANS, right? You ask me, I will tell you about human behaviors. Behavioral, storing water for dengue. Don't go out into the forest for KFD. You cannot. It's very difficult. It's easy to give a lecture. Very difficult to change somebody's behavior. So that would, it's a broad definition. These are the challenges. Where encephalitis cases occur, no laboratory facilities are there. In and around Gorakhpur, you don't have a virology lab. Only now NIV has come up, or in Bihar for that matter. Then there are no standard testing algorithms. What was the government doing? Only JE. From 2005, testing only for JE. No sample collection, transport, referral system, and poor collection of data collection tools were bad. With these challenges, CDC Atlanta requested us to do something, and we did it for 5 years in 3 high-burden states, UP, West Bengal, and Assam, that accounts for 70% of encephalitis burden. So what did we do? We set up surveillance. First challenge, I went from here, I went to UP government, they threw me out. They said, you are trying to teach us encephalitis, get out. You are from South, what do you want to do here? Uma has faced this, I'm sure, in any number of places you go. Then what to do? Go to Delhi, catch hold of NVBDCP, ask them to tell, no, he is not an enemy, he is a friend, he wants to help you. Then ask them, you please tell me which sites I have to do surveillance. If you tell, I want to do here because disease burden is more, that's what the data says, they'll throw you out. Always tell them, but you tell me what you want and I will help you. Once you get your foot in, it's the camel and the Arab, right? Once you get your foot in, do what you want. Till then, I mean, these are not in textbooks. I'm talking of straight from my experience, I'm telling. This is not there written in any textbook. How to get, somebody was telling how to get data from government. They won't give. Why should they give? You are Maharaja of Mysore. Yeah. That's all the more reason why you should start surveillance, right? If there's no data. So I'm telling you that these are the challenge. Don't, see, one thing is don't give up. Don't give up. If you're passionate about something, don't give up. Find a way. There's always another. If you don't know, ask Chat GPT, boss. It'll give you an answer. Only thing, whether it's good or not, you have to decide still. It may throw out some trash, but it'll give you some idea. Then what we did, there was no testing algorithm. Everybody says, government says, test for JE, we are testing for JE. There are other causes of encephalitis. Why can't we test for them? Then reluctantly, all clinicians and public health people don't see eye to eye. So you have to get them in one room, ask them, and they give you a laundry list, 110 pathogens. You know, in that place, some Congo hemorrhagic fever caused encephalitis. You prune that to a practical list, and then we establish a laboratory network. Peripheral laboratories can only do serology, they can't do PCR, they can't do sequencing. So we married some base labs to a referral lab, and then NIMHANS as the super referral lab, did all this. It took about 1 to 2 years to do all this. Then we knew that if they can't test for all pathogens in, let us say, in Devriya district, you have to send it to Lucknow and get it done. Deep part of Assam, Shibsagar, send it to Dibrugarh. Like this, we network. All this, by the way, was mind maps. What is the challenge? How can we overcome the challenge? Go to the drawing board, sit there, and then go back and implement it in the field. And then we found that, you know, one of the tools that is used, I don't know if Tenzin talked, I came a little late. It's called a line list. You know what a line list is? You know what a list is, right? Many rows. Line list is many rows with many columns. How many columns? Is there a limit? No. Depends on what data I want to collect. Name, age, hospital ID, location, symptoms, signs, laboratory findings, outcome. Like this is called a line list. Uma is very familiar because we used to get thousands of line lists during COVID. It's a great resource, provided it is correctly populated. If it is not, it's useless. So how do you do it? Till we did this project, everything was manual. People had to enter, or they used to do in an Excel sheet in computer. So that's when we came up with a mobile phone, smartphone app, where you have what is known as, you know what radio buttons are? Mandatory. In a Google form, unless you fill that, you cannot move to the next question. That kind of application, open source tool we developed, that we handed over to government of Uttar Pradesh. I'm sure it's somewhere deep in the Ganges in Varanasi. Okay? You can do this. You can do this offline in a village, save it. Then when you come to an area where there's internet connection, it'll come to the central lab. So what I'm trying to tell you is, there is technology available now, which Tenzin was telling. Use the technology. Information, correct information, and complete information is crucial for outbreaks and for surveillance. So that is the data collection piece that we had to do. Because this is the map and these are the sites. I won't go into details. Then we came up with this algorithm. Because Government of India said test for JE, first test for JE. If it is negative for JE, then test for dengue, then test for scrub typhus, which was reported, but nobody had tested for it. And then you test for all the other ones that can possibly cause encephalitis. For some of them are serum tests, some of them are CSF-based tests. Some of them are serology, and some of them are PCR, molecular technique. In spite of all this, they still be negative. Then came my dear friend and colleague, Chitra, who is a sequencing expert. She took up those specimens and did genomic sequencing, and we found pathogens that were not there in any of this list. So actually, it's very exciting Sherlock Holmes type of work. You ask Uma, and whenever she talks like Sherlock Holmes, very passionate about whatever she does. Now, what is the output? Because I titled this section what? Output and outcomes, right? What was the output? This is the world's largest encephalitis syndromic surveillance. 14,000 patients who were tested for antibodies and antigens in one arm, PCR on the other arm. Out of these 14,000 patients, we got an etiology totally in 54%. Till this surveillance was established and run, we used to get 8 to 10% only Japanese encephalitis. We were not testing for the others. Okay? Among these 58%, 48% of samples had a single pathogen. The remaining had positivity for multiple pathogens, a reality in whatever you do in the field. Is it a lousy test? Maybe. But I can tell you from my experience, dual infections are not at all uncommon. They're quite common. Because all of them occur post-monsoon. Right? I've seen children with pneumococcal meningitis and Japanese encephalitis, scrub typhus and dengue. But we didn't consider those. 8% we excluded because there are multiple pathogens, but still 48%. From 16% to 48% is a huge jump in terms of determining etiology. And the commonest among all these were three. They accounted for 80% of cases: JE, dengue, scrub. What is the good news? Scrub. Because it's treatable. You just give doxycycline, a child from coma gets up and walks home. You see full page ads with Yogi Adityanath ji saying how he championed encephalitis, right? This is the work that helped Yogi Adityanath champion encephalitis. So what is the outcome? That was the output. Output was we increased detection. What is the outcome? This was the most satisfying part of my life. We enhanced etiology threefold. We identified treatable causes of encephalitis. You give a treatment, the child recovers, gets back home. Based on that, a health secretary of UP, maybe Tenzin will know. I remember her, she's still there in the government. Hekali Zuzumi, she's from Arunachal Pradesh, not more than 4 feet 8 inches in height, like a schoolgirl. I was in Atlanta presenting the findings. She called me on WhatsApp and said, Dr. Ravi, I want to talk to you. I said, what is it? You identified scrub, great work. Can you tell me what we can do to prevent? That's when we said empirical. When a child comes with fever, altered sensorium, collect the samples, give doxycycline. It's a safe drug. Let the lab results come. Because earlier you give doxycycline, the chances of recovery are much more. Right? And I can show you within 24 hours, she issued circulars. This is in Hindi. I can share the circular with you. UP. Then what did we do?
Sir, but scrub typhus is always misdiagnosed as other febrile illnesses.
Correct.
So, in that sense, there is a chance that people might misdiagnosing scrub typhus when it is a scrub typhus case, right?
Yeah, that's the biggest thing. That's what we showed. My dear friend Arun Kumar, whom Uma knows, was in Manipal. He parallelly was doing febrile illness surveillance across the country, and he also found scrub typhus very common. There also we implemented empirical doxycycline treatment. Then what did we do? Politics. We took this circular of UP government. He's a Bengali. Went and gave it and said, you know, UP is doing this. They also issued a circular. Then ICMR, Nivedita and others called us to present the findings, and NVBDCB recommended merely testing for Japanese encephalitis is not enough. You should also simultaneously test for dengue and scrub because they are serology tests, easy to perform. Leftover samples, this is the algorithm, you should do PCRs and finally end up in sequencing. Now that is a national policy today. So it was very gratifying, very gratifying to do something from scratch and see a policy change. This is published in Lancet Global Health. It's a very highly cited publication. You can see it in Lancet Global Health. COVID taught me all my 40 years experience was distilled and put into a flask and given like a poison and said, work for COVID. I was talking to you about line list, right? This is a paper we spent maybe around 150 hours just mining data from line list. Don't laugh when I tell you this. The point of this paper is to say symptomatic people are super spreaders compared to asymptomatic people. What is symptomatic people? Those with COVID who cough and sneeze throw out more virus. This is common sense. But I tell you, it requires a lot of work and data to prove common sense. This is mined from the line list. It's a beautiful Rangoli, right? This is a central patient who was symptomatic. From the line list, we could know that this person was contact of this person, and that person. So we did this cluster mapping. And this is the cluster map. The chota ones are asymptomatic, where it is yellow. Those clusters you see are not very big. Wherever the red center person is symptomatic, spread more. This was there. But it took 7 revisions and 8 referees to argue, because somehow they said, no, you're giving. I said, I'm not giving a message, asymptomatics don't spread. Strategically, if somebody is symptomatic, he should be masked and staying at home. If you are asymptomatic, boss, I don't know that you are carrying the virus, right? I can't isolate you. But if you are symptomatic, even today this is true for all respiratory viruses. If you have symptoms, please wear a mask. Transmission is reduced 90%, 80%. If everybody wears masks, we showed in COVID, it comes down by 95%. Right? But a symptomatic person wearing mask, 80% you can reduce. That's why in the West, if you're not well, they say, don't come to work. If you're having a cold, they say, why are you coming to work today? Because you'll spread it to others, right? But this is a very costly message. Huh? It took so many brains, so many line lists, government line lists, 150 hours of work.
But I think what is really important, we were discussing it earlier also, that many times we have some intuition, but actually having data and showing that is much stronger and a good culture going forward, because otherwise we just depend on intuition.
The chief editor finally wrote that, I wish I'd made a slide of that comment saying that excellent quality of data and very good analysis. This is something that, the reason why we are publishing, and we are happy to waive off the 2,500 pounds. Genomic sequencing. Dr. Tenzin was telling tools have improved now. Now Darshan is sitting there behind. Another, not this Darshan. Your Darshan, right? There's one more Darshan. Raise your hand, Darshan. He did all the donkey's work in the lab, and I'm doing the talking, right? He was in the lab. He did a lot of nucleic acid extractions, PCRs. Closing his eyes, he can set up a PCR now. And then, of course, sequencing also. So, sequencing is a very powerful tool today. And you can ask Dr. Uma, I'm sure you heard her talk, and you know what a powerful tool it is today. The reason why I'm showing you this is tools are very important. The previous slide I put why data is very important. Quality of data is important. Here I'm telling you tools are important. And the slide before that, what did I tell you? Strategy is very important. Don't give up. Because when the fruits ultimately come, it is so satisfying. Whether there's a publication or not, you will sleep peacefully that night, believe me. Right? That's something beyond. That feeling is something beyond. So here, now, because of this genomic thing, we know today we can map to every street corner and every gully where it originated. You can do, epidemiological mapping. It's a wonderful tool. You can predict outbreaks much before by doing sewage surveillance. NCBS has been at it, and so is TIGS and other places they are doing. They are now doing sewage surveillance for AMR. To that level it has come, right? So this is, you should know that, but it cannot serve the purpose for every surveillance that you want to do. If the bug itself is not found in human tissues, very rarely, like in Japanese encephalitis, you can't do genomic surveillance. Serology is, by the time the patient has Japanese encephalitis, the virus has disappeared from all over the body except the brain. Only evidence is antibodies to it are present. That's how we diagnose Japanese. When the virus is not being shed, where's the question of, or secreted into the blood, where's the question of, and the amount of virus is so less, it's going to be very difficult. But where it is available, it's a very powerful. This is the story of INSECOG. We were some of the founding members of INSECOG, Uma, myself, both you see, Bangalore, there were 2 labs at that time. So INSECOG today is a network of 60 labs doing great work. Even before INSECOG came, because Chitra was there and we had access to samples, we were able to do epidemiology, molecular epidemiology, using the specimens that came and showed how COVID virus entered Karnataka, how it matched sequences from other parts of not only India, but from other parts of the world as well. So you can do wonders with genomic work. Now this is the largest surveillance that is available in the country, the biggest platform. It's called Integrated Disease Surveillance Program, IDSP, physically located its headquarters in NCDC, along with Dr. Tenzin's, unit. And they have, the country has, it's been conceptualized very well. Many things are in place, but a lot of groundwork is missing. Let me be very honest. But that is because the states are responsible for that. The way it is organized, I'll tell you, this surveillance, because maybe I'm giving a 10,000 feet level gyan for you on surveillance, but that's very important. Tomorrow when you go out into the field, you should know. How is it organized? There's a central unit, there are state units, and the core is a district unit. Central Surveillance Unit, CSU, SSU, and DSU. And there is a surveillance officer. There's a CSO, there's a DSO, and there's an SSO. Okay? So if you want any information, these are the guys you have to get friendly with. Okay? Now the base unit from where all data flows upwards, the bottom of the pyramid, is a district surveillance unit. Where does it get its information? It gets it from primary health centers, community health centers, district hospitals, medical colleges, public health labs. This is the government system. It also gets it from private practitioners, nursing homes, private hospitals, corporate hospitals, and all other hospitals in the ESI and so on. And then it populates the data upwards. So the concept is great, but the elements work with different abilities in different states. Southern states, IDSP works wonders because health systems are very strong. Some of the northern states, I'm not being parochial or discriminatory here, it's the way the whole, the states have evolved. Some of them are good, some of them are evolving, some of them are really bad. You have to acknowledge that. What is the type of surveillance? By the way, this is passive surveillance, okay? Actively, we are not looking at anything. This is passive surveillance, collecting data on what is happening at various health facilities. And what is it? It is syndromic in nature. And this syndromic does not require any laboratory investigation. So people fill out what is known as an S form. That means syndromic form. Syndromic means so many patients had fever, vomiting, and diarrhea. So many patients had fever, altered sensorium, fever and rash, fever and joint pains, jaundice, so on. That is syndromic surveillance. From there, that is the first step. From there, you do presumptive surveillance. Presumptive means some clinician has looked and made a provisional diagnosis without a lab test. That's the P form. And then comes the L form, where laboratory test has been done and it has been confirmed. Okay?
There's no active surveillance for anything in India. Is that correct, or it's all passive?
No, there are active surveillance.
Okay. For
Tuberculosis, malaria is active surveillance.
KFD also. Okay.
Yeah, KFD, there's active surveillance. What does IDSP do with all this? It's supposed to, actually this data is supposed to flow weekly, if not daily. And in a week, there are 52 weeks. At the end of every week, they are supposed to do something, right? The 3 levels of responses. Level 1 responses, if it is something like a flu outbreak, a respiratory, then it's very high alert. So they send out a rapid response team. A rapid response team typically will have a clinician, a public health person, a lab person, and a veterinarian. At least on paper, it has a veterinarian. Right? In the original WHO thing, it is there. Okay?
But right now, it's not in practice.
It is there. Veterinarian is there. And I think we should have an environmentalist and an ecologist moving forward if it is an outbreak, right? Then level 2 response, if it is contained, fine. Otherwise, you have a level 2 response, you scale it up, multiple departments will be involved, okay? And there will be teams that will be working round the clock to solve the problem. Basically, dousing the fire where the source of the fire is. And then, of course, is level 3 response, something like COVID, 24/7, whole lot of sectors involved, and it's wide, and you're dealing with like either an Ebola outbreak in Africa or a COVID or a SARS type of response. Well, this is the promised document. Please have a look at it. Download it from the net. This says Vision 2035, Public Health Surveillance in India, a white paper. I know many of them who contributed are very dear friends I worked with. Dr. Rajesh Bhatia, I mentioned. Samiran Panda was an ICMR. So this is something that you should read. And a small tip, how many of you read actually? Be honest. How long do you read? For all the others, just download this document. Adobe has an AI-free engine. Give it to it and ask what is the summary it will give you. Have you used that? Hey guys, you are at 70. I am so technology savvy. Come on, yaar.
Sir,
Adobe comes with a free AI tool.
yeah, I just have a habit of giving the search term KFD every night before I go
still
to
read.
bed.
I still
Choose
read.
the tool past 24 hours, what's happening. I will get at least one hit every day. If it is a paper, I will just go through the abstract.
Nothing
if it
like
is
reading.
interested,
My
then I'll
boss
go
who
through.
trained me at Jipmer in Pondicherry, every day used to kick me out of the lab at 4:30 and till 7:30 you're supposed to spend library, read, and next day morning for 15 minutes present what you read. After 5 years of training, it became a habit. So, see, there's so much of information that is available. And you have to read. Don't simply rely on Google searches or AI searches because there's so much of junk. You should know how to sieve grain from the chaff. Don't be a slave of searches. Okay? But there's no substitute to reading. That's my last slide. I know I've spoken a lot. You guys have any questions?
So we are very fortunate to have you here. So just because of your experience and outcome of your effort, so really we appreciate. And one thing I observed that you said the importance of surveillance. Is some disease, look at the polio. Even though it is under control, still you are keeping the surveillance. And the other, still it is not there. Still we are expecting that surveillance is very important to predict when it comes. The other part, the HIV, malaria, tuberculosis, some diseases, keep increasing the mortality as well as incidences. Is that due to because of lack of strong surveillance report or lack of implementation of the output of the surveillance?
It's the second part which you said. If you remember my slide, there is no action. There's only information collection. Having said that, I must tell you that there are some diseases that are challenging. If you are an avid reader, I would recommend a book on HIV/AIDS known as My Own Country, written by Dr. Abraham Verghese, who happened to be my MBBS classmates and eating out of my tiffin carrier. Now he is the vice chair of medicine at Stanford. The last line in that book says, there is more to AIDS than the virus. Very true. Virus on its own doesn't jump from one individual. It's not like COVID. It's not like Ebola. Touch, contact, air, aerosol doesn't spread. You require a human behavior to spread it. Wherever behavioral components are involved in disease transmission, It's going to be very difficult. COVID was fantastic because all you needed was a vaccine. And the whole world worked on it and got a vaccine out. And has it changed behavior? Absolutely not. People still sneeze and cough in Bengaluru metro. You ask me, I use it. They don't cover their face. That's a behavior, right? So there is, but surveillance is required. And surveillance should result in action. I'm so happy that although AIDS is a behavioral disease, all over the world it's coming down. We're not eliminated. We're not going to eliminate it because it's something, it's a very intimate behavior we're talking about, sexual behavior of somebody, right? That's not going to get eradicated. But a lot of things have brought the curve down, mainly antiretroviral therapy and a lot of social, commitment and education. You very rightly summarized saying that we are doing surveillance for what? To see if we can bring down the incidence of a disease. But more importantly, we are doing surveillance because if you don't have surveillance, you won't know what came new. Or it's an old thief or a new thief. We won't know.
So, yeah.
Thank you for the talk. It was very interesting. My question is related to that specific lychee encephalitis. So after figuring out, first of all, how did you figure out there was a toxin and what the source was?
Okay, right.
And after figuring out whatever the toxin and its source, like you said, many people are not privileged enough to have food and meals. So what other steps other than suggesting, feed your kid?
Okay, thank you. Thank you for asking that question. How did we figure out? The hard way. Subjected the samples to more than 24 high-end tests. And there was not a bug anywhere. There was no antibody to anything. Nothing was there. Then came the question, is it a toxin? So there was analysis done on the lychee. Ripe fruits have, I forget the name of the toxin, it's called MCTG. It is a toxin that is involved in the Krebs cycle. There's a lot of hardcore biochemistry. It prevents glycogen breakdown. So even if there are glycogen reserves, it is not broken down, and so that was the logic on which the intervention was designed. Okay, the fundamental principle. Only the laboratory finding that came was low blood glucose in all of them. Then the question came, why low blood glucose? So is it starving? There are other children starving who have not died. Non-lychee group, the control group. Not non-lychee harvester children. They were not dying. So is there something in lychee that brings down that's the question was.
But you must have done some HPLC or something.
Absolutely. After that we did this at Nimhans and also in another lab in Delhi. We did blood collection of dried blood spots and ran the complete metabolic profile and showed that there is the Krebs cycle is altered. And that's when one of my colleagues also said that if you can't give food, if you can give carnitine syrup with riboflavin, because now I'm very poor in biochemistry, but I have the slides, I can explain to you how the whole thing works. So carnitine and riboflavin, which is a coenzyme in the Krebs cycle pathway, the whole thing was established. So carnitine syrup. And I must also tell you, you learn very wonderful lessons in the field. I was talking about scrub typhus. So in a remote PHC in UP, he said, very academic, doxycycline syrup is not available. Nobody makes because there's no money in it. So I said, open a capsule, empty the powder, mix with honey, give half because that is adult dose. In the field, practically, then the doctor, elderly doctor, put his hand and Doctor Saab, यहाँ मधुर नहीं मिलता है. What solution are you giving? Then I said, do you have a solution? He said, yes, we have B complex syrup. Mix it in B complex syrup and give it.
Sir, regarding cases of unknown etiology, still you say like 50% of cases are like that. How big the problem is?
By the way, it's 75% now because with sequencing, you can improve another 15-20%. There are other bugs. Yeah, anywhere in the world. Even go to CDC, anywhere in the world. Why? Right? Yeah. Why? The answer is, you collect samples in a window. The disease started here, it is progressing to the end of the table. You collected samples at one window. Not all analytes will be present in that window. So what you need is a moving window, which means you need serial samples. That is very difficult to get because the person either recovers and goes home, you will not get a sample, or the person dies, you will not get a sample. So you'll have to live. You will not get 100% results in any surveillance. The fundamental principle of data interpretation, especially Tenzin would have covered it in the outbreak, is if 10% of the samples are positive for something in an outbreak, most likely that is the one that causes the outbreak. In the absence of any other thing lighting up, all the 100% will not give you positive.
I have a naive curiosity. Why does it affect only children, the lychee toxin? Why are children only the reported cases?
Adults have humongous amount of glycogen stored in their liver. And these are poor children, undernourished. Undernourished children will not have glycogen reserves because they're starving, they continuously burn. Glycogen is the storage, right? It continuously, there are no stores. So poor, undernourished children who have not eaten anything whole day in hot summer and swallowed only lychees to fill their stomach. So as soon as I came back and I started presenting my findings, everybody in Immense jumped at me and said, oh, I eat lychees. Boss, continue to eat lychees. Nothing will happen to you. You have 1 ton of glycogen in your liver. Nothing will happen. Lychee is not bad.
Hello. So great talk. I'm just dragging on to Kanika's question on lychee, this lychee question. How many subgroups did you all have when you guys were not aware that the toxin was from lychee? So you had one group that were kids who were already affected by it.
The control group was other children admitted with fever to pediatric wards.
Okay.
Disease control group. Very difficult to get a healthy control group. I worked with children all my life. No mother will allow you to bleed a child so easily.
Yeah, makes sense.
So it was febrile illness, admitted to the pediatric wards. We had twice the number of controls compared to the affected children.
Hello. So one last question. This is as a researcher out of curiosity. I know sir since 2018. First time I was introduced by him, him as Virus Ravi. That's his nickname in the
address.
state. Yeah.
That's my email address.
Also in the
virusravi@gmail.com.
Yeah. So it's also an inspiration for me in the virology. This is regarding COVID with your experience in last 5-6 years. How do you conclude this COVID, whether it's a man-made or a natural?
I stopped
Debating.
drawing conclusions.
Okay.
Sometime back in my life, due to various scientific and personal experience, I only look at lessons.
Okay.
You are not going to prove whether it is man-made or whether it is natural. There are wonderful evidences for both. Right?
Yeah.
For natural evolution, there are a series of papers on bat SARS-CoV-2 surveillance that took place in Cambodia, Vietnam, Japan, where the furin cleavage sites were already present in those bats naturally. Okay? That is the natural evolution. The man-made theory is again because of the furin cleavage site. Why it came only in this virus? There was a institute close to the Wuhan market, and their biosecurity was atrocious, right? NIH had funded a project on looking at the functional gain in this bat virus. We don't know, but the lessons are simple. There has to be extraordinary biosecurity in labs that work with bugs. There's no doubt about it. We need to tighten our belts. And second, we need to set up surveillance more in hotspots. Now, what are the hotspots? Wherever there is man-animal-bird interface. Uma and I have discussed this many times. And in India, if you ask me hotspots, it will be Western Ghats and it will be Northeast, where naturally man-animal-bird interactions occur in a very large scale and sometimes even in crowded settings in high concentrations. Uma is a better person than me. She will tell you about the bat caves in the Northeast. And there are bat festivals where they smoke the bats out, they collect thousands of bats and they eat it in Nagaland. Am I correct, Uma? And I can tell you where the next zoonotic outbreak will occur. It will occur either in African jungles, in South America, or in whole of Southeast Asia like China, Vietnam, Cambodia, because they are all wet markets in these areas. South America and Africa are jungles, where man is, right? You should read a book called Dancing Matrix. I don't know, I read a lot of books. Please get that book. It's available on Flipkart. It talks about how the viruses and bugs have had their own highway and they're very disciplined. They're going in that highway. Man has systematically crisscrossed the highway and invited trouble. You know, Kerala never had Japanese encephalitis. Japanese encephalitis, in my lifetime, I worked a lot on Japanese, was a strict, if you split India vertically, it was a eastern disease, never western. In 94, the first case of Japanese encephalitis was reported in Kerala. After that, it has become endemic in Alleppey district. You know why? Alleppey is one district where they attempt to grow rice and they grow rice. And during high tide, backwaters used to come and salinity used to ruin the paddy crop. 1992, Manmohan Singh became the finance minister, globalized economy, World Bank funds came, and there was this smart, young, I don't know whether it's a doctorate or a postgraduate agriculture minister in Kerala, who actually said, I'm going to solve this. He got money and built a bund to prevent high tide water coming inside. 93, they had a bumper crop of paddy. 94, they had a bumper crop of JE. Paddy field, migratory birds, Culex tritynorhynchus, it set off a cycle. Again, Congo hemorrhagic fever, you know how it came? Building a dam across the Congo River. Vector population increase.
So also I think one of the interesting, we are talking about capacity building and stuff, is also with bureaucrats.
Absolutely.
And
Absolutely.
with because sometimes these are all in thinking about development. Many of these decisions are made without having a full cognizance of what their impacts might be.
Absolutely.
So that's
And
something
where,
which
see, we
important to
don't
consider.
have public health engineering as a specialty in most parts of the world. We build whatever we want without any concerns. You run highway across South America through the Amazon jungles,
Yeah.
and you invite a whole lot of viruses.
Yeah.
Who asked you to build a highway across the jungle?
There was a question somewhere here. Yeah, Ashwin, go ahead.
There is a my sir. Here.
Yeah.
So it was a great talk, sir. So you talked about we can't change the human behavior at present situation, but
it's very difficult.
Difficult.
I don't say we can't change. Behavioral change is very challenging. Let's do an exercise. Okay. All of you fold your hands like that guy. Just fold your hands, no? Look at it. For some of you, the right hand is above. For some of you, the left hand is above. Right? Can you undo it and put it the other way around? Is it comfortable? Something like folding hands is a behavior. All I did was change it the other way around. It is not easy. Not at all easy.
By your inputs, can you, for your future generations, can we implement any criterias or any implementations where we can change this spreading of diseases, like to educate the young minds and younger generations? What are the precautionary measures we can take by your data?
Let's take what is happening in Bengaluru today. Every day, dengue cases are rising. Right? It's not fault of the virus, it's fault of the human beings. We know that small collections of water Aedes breeds. It all outbreaks, you know where it starts? Where I work in Whitefield. Cholera, dengue, COVID, everything starts in Whitefield. Supposed to be the IT hub, okay? There's a lot of construction. There's a lot of migrant population. You can't say stop construction. But if you be disciplined in construction, there won't be water puddles. Right? There's no water shortage, there won't be people storing water. It's very difficult. What we do cosmetic measures like going around foggy. Doesn't do anything but make you sneeze and cough and make you breathless some places because it doesn't do anything. Doesn't kill the mosquito, it only drives the mosquito away from your house to your neighbor's house. Spraying. So, see, we know what is to be done, but it's very difficult because it involves community participation, it involves.
Yeah. So, during COVID, this government app, Arogya Setu, was there. How much was it useful in the surveillance, since everyone was mandatorily asked to download it and use it?
See, Arogya Setu did help in tracking. But the difficulty was if you had downloaded. If you're not downloaded, it can't help you in tracking. Where it was downloaded, it helped in tracking. One of the first surveys during COVID that we conducted was coordinated by Tata Consultancy Services, TCS. The first survey was done in Kolar district, and myself, Anurag Agarwal and Gagandeep Kang were the people who gave the framework for surveillance. And it was started in end of March 2020, just when the first lockdown was happening, and concluded in May. The question being asked was, does Kolar have COVID? If so, how did COVID come to Kolar? One of the knowledge partners was IIT, Professor Kamakoti. He's a great communications person. So we used antigen detection, antibody detection, imported the kits from South Korea, and then we did virus isolation. And we did strategic sentinel surveillance picking up from various taluks of Kolar. The sum and substance of that, we call this minimal testing, maximum intelligence. About 350 or 400 samples we did. And we showed that there were 12 cases of COVID in Kolar. All of them had come to Bangalore, visited a house where a person was suffering from COVID. How did we establish it? Through their mobile phone conversations. And then interviewed them and they said, yes, we went to this house and that person had COVID. I don't know if I answer your question, but I tend to tell a lot of stories. That's my problem. It's a problem of all Jipmerites. Yes, sir.
Sir, I heard I'm feeling very blessed to listen to your lecture. I'm listening about you since 2009 in NIV Pune, like Gadkari sir and Deshpande
Yeah, my
sir.
old friends.
Yeah. And Jacob Johns. Yeah. Everybody, like how you build this network, like how you communicate for collaboration, and I want to learn that.
I mean, you're asking from a career perspective, right? I was very clear I wanted to do virology. In Jipmer, after my MD, I worked only in virology for 2 years. I have a very, very personal reason, I won't go into it. I did virology. And I wanted only a virology job. I rejected 8 jobs, some very plumb positions, including Assistant Director of Kasauli Institute, Manipal faculty, CMC Vellore faculty, in microbiology, not in virology. So I got this chance. And the reason why I'm telling you is, when I came here, there was nothing, a table and a chair, in 84 December. I had to build everything from scratch. But I had a very supporting director and institute then. So I went around asking, what should I be doing? And everybody said, whatever you do is virology. And I was so insecure at that point. Not insecure, I was feeling helpless. I did not have support. So I networked with NIB, with CMC, with NICD, with every health agency, state government. Bellary, there were JE outbreaks, KFD, Shimoga outbreaks. So that gave me enormous, what shall I say, field experience, enormous experience. It also gave, slowly I started building skills of communicating with people, in a non-threatening way and saying, we can work together. These are soft skills. And I chose something and I was thrown into something where nothing was there. I had to fend for myself. That helped. So that helped to come from the bottom, it helped. So that as you ascend up, you know everything that happens in the bottom, including what happens in the field.
And also I think it's really important to not be scared to ask.
Yeah, you have to be very bold and open to criticism, failures, accept failures.
Don't ask, anyway you fail.
Yeah.
Get it. So it's okay to ask.
Yeah. And also, it's very important to dream. There used to be a magazine called Punch. I don't know. Most of you would not have been born when Punch discontinued. It's a very sarcastic, humorous British magazine. And every issue of Punch used to have a story and a moral. Freaky Fables, it's called. Right? One of them stuck to me when I was in Jipmer. I used to read that. It said, aim for the unattainable. The inevitable will happen anyway. But don't be stingy in dreaming. Don't be stingy in dreaming. Don't give up saying it will. But everything will happen. You should have the patience and the knack to get it done. That's all.
Okay, thank you so much. I think that's a great time to end. So thank you so much.